So lung and diaphragm protective ventilation is an important new idea in mechanical ventilation, and it's really been coming together over the last 10 years or so, building on the work of many people who've gone before. So in the next 30 minutes or so, I want to introduce the concept, explain what it is, why it's a thing, and how it might work. We're of course at the very early stages. We need clinical trials. We need more mechanistic studies to work out some of the priorities for the strategy. But I think it's an exciting time. It's an important concept that I hope will improve outcomes for our patients. So just briefly, my disclosures, some equipment and support from Timpel and Goligher. So I think you probably all know the story of how mechanical ventilation kicked off in the early 1950s. There's the famous story of Bjorn Ibsen and the outbreak of poliomyelitis in Copenhagen. And in the short period of time after Ibsen introduced positive pressure ventilation via tracheostomy, mortality dropped dramatically from 87% down to an average of 40% over the ensuing months. And so the introduction of positive pressure ventilation, mechanical ventilation, as a replacement for the iron lung was a dramatic improvement in outcomes for patients with respiratory failure. And so very quickly after that, the whole concept of an intensive care unit came together, and ICU started to sprout up around the world. And so I think we can be pretty confident that modern mechanical ventilation saves lives. Moreover, we can be pretty confident that modern mechanical ventilation applied in a protective way saves lives. So within 20 years or so of the introduction of positive pressure ventilation in clinical practice, it became clear from experimental studies such as that from Webb and Tierney that depending on how you apply the ventilator could have a significant impact on the patient's lung and then potentially on the patient's outcome. So this classic figure from Webb and Tierney's paper published in the 1970s highlights the fact that very high pressures and volumes applied to the lung result in acute experimentally induced pulmonary edema. And as you know, over the ensuing 30 years, lung protective ventilation strategies were developed, and the ARDSNet trials, this sort of classic trial demonstrating the benefit of a low tidal volume, low lung stress ventilation strategy. But as intensive care has improved and as survival has improved, we've come to appreciate more and more the importance of the sequelae of being on the ventilator, the long-term functional impact of critical illness. And work done by Margaret Herridge here in Toronto and groups all around the world has pretty convincingly demonstrated that many patients, particularly those who are on the ventilator for a prolonged period of time, are at high risk of long-term disability. So this figure on the left here is some data from Unrow and colleagues that's now almost a decade old, showing that among patients who are on the ventilator for at least 21 days, at 3 months, nearly all of them have some functional dependency, and many have complete functional dependency. And even these patients tend to deteriorate rather than improve over time. Carol Hodgson published a systematic review a couple of years ago looking at risk factors for long-term disability after mechanical ventilation, and she found clear evidence that a prolonged duration of mechanical ventilation is an important risk factor for disability. So although we use protective mechanical ventilation to get patients through their critical illness and survive to ICU discharge, they're still left picking up the pieces, and delays in being liberated from the ventilator is an important contributor to long-term disability. Now, a key piece here is the potential impact of mechanical ventilation on the diaphragm. So, as you well know, the mechanical ventilator can cause acute diaphragm atrophy and injury, and we'll discuss this in somewhat more detail. And this was first described by Knisley and colleagues in the 1980s in an autopsy series of neonates submitted to mechanical ventilation for 3 days versus much longer periods of time. And as you can see, a clear difference in myofibril cross-sectional area here, suggestive of the development of diaphragm atrophy during mechanical ventilation. And the diaphragm is the primary muscle of inspiration. It's crucially important for the patient's ability to tolerate inspiratory loads. So the possibility that mechanical ventilation might actually be causing deleterious structural changes within the diaphragm, which then perpetuate ventilator dependence, leads us to be very concerned about the need to not only protect the lung during mechanical ventilation, but also to protect the diaphragm. So this leads us to the concept of an integrated approach called lung and diaphragm protective ventilation. So the idea here is that ordinarily we focus on the impact of mechanical ventilation in terms of its effect on acid-base homeostasis and achieving adequate minute ventilation, while at the same time trying to prevent volutrauma, which is the main injurious effect of ventilation on the lung. And so for this reason, we employ lung protective strategies like low tidal volume ventilation, and an argument can be made that ECMO is really a lung protective intervention. But what I'm proposing here, and what we're going to discuss in some detail, is the idea that we add a third priority, a third target to our ventilation strategy, which is concern for preventing diaphragm myotrauma, which also can impact clinical outcomes. And in order to do that, we need to introduce diaphragm protective ventilation strategies, potentially ECLS, and by monitoring and optimizing respiratory effort and patient ventilator synchrony, we can protect the diaphragm and thereby potentially improve clinical outcomes. And the big challenge is that sometimes the lung protective intervention interferes or conflicts with the diaphragm protective intervention. So figuring out how to balance these two priorities at the bedside remains an important clinical challenge. So this is what I basically want to survey: the relevant mechanisms and the relevant clinical considerations over the next minutes. Okay, so about a year and a half ago, we published this paper in Lancet Respiratory Medicine that tries to summarize the major mechanisms by which the diaphragm can be injured during mechanical ventilation. We refer to this general concept of diaphragm injury from mechanical ventilation as myotrauma. So just like you have volutrauma and barotrauma and atelectatic trauma, well, we propose the concept of myotrauma as a way of thinking about these mechanisms at the bedside. And we identified three key mechanisms with varying degrees of evidence to substantiate their importance. First of all, over-assistance myotrauma, the idea that excess onloading of the muscles can be injurious. Secondly, under-assistance myotrauma, the idea that insufficient onloading of the muscles can be injurious. And then eccentric myotrauma, which is a particular form of load-induced injury that we'll discuss. And then fourthly, there's a hypothesis of what we call expiratory myotrauma, where prolonged maintaining the diaphragm at a short length for a prolonged period of time induces what some have called longitudinal atrophy. So we'll just briefly summarize and discuss these mechanisms. So the first, and by far the most well proven and well understood, is what we call over-assistance myotrauma. And over-assistance and excess on loading of the muscles results in acute disuse atrophy. And this has been demonstrated convincingly experimentally in many different animal models and also in the clinical setting. Perhaps the classic description of this problem comes from Sandy Levine and colleagues, where they obtained diaphragm biopsy specimens from subjects undergoing thoracic surgery for 3 to 4 hours. Those were the controls. And then from brain dead organ donors who'd been brain dead for anywhere between 18 to 69 hours. And what you can see here is that when you compare the two sets of histology side by side, you can see a marked difference in myofibrillar cross-sectional area between cases and controls. And interestingly, this difference in myofibril cross-sectional area was not present in pectoralis major. Here you can see similar average cross-sectional areas between within fiber types of pectoralis major between cases and controls. So this is really a specific atrophy of the diaphragm developing in patients who are brain dead with respiratory quiescence for just 18 to 69 hours. So a very rapid onset phenomenon, just like that which had been described in animal models. Secondly, there's concern about the possibility of under-assistance myotrauma. This is a load-induced injury to the muscle that occurs as a consequence of failure to adequately unload the muscle. So the idea that loading can cause acute injury to the diaphragm has been documented thoroughly in animal models. A Canadian investigator by the name of Darlene Reed did many different experimental models in which she described the fact that when you apply a mechanical load to the respiratory system, that elevated respiratory effort over a relatively brief period of time of hours to days results in acute injury. So in comparison to control subject here, you can see the nicely organized muscle architecture here on the left. You can see that after a period of resistive loading, you've got disarray of the muscle ultrastructure, you've got inflammatory cell infiltration, and acute onset muscle weakness that interestingly develops over a period of 2 to 3 days. And this phenomenon was a bit controversial because there are some studies showing that immediately after resistive loading, say for example during a spontaneous breathing trial, when you put the patient back on the ventilator and measure diaphragm strength, there's no immediate development of weakness. But in fact, it seems that the resistive loading results in an inflammatory response that takes place over days rather than immediately after the load. So that just as the day after exercise, you can have delayed onset muscle soreness, that's also the timing when you start to see injury from load-induced injury. So this is a phenomenon we refer to as under-assistance myotrauma. I'll present some circumstantial data to suggest that this does develop in mechanically ventilated patients. Then there's this third mechanism, which we refer to as eccentric myotrauma, which is a specific type of load-induced injury. So whereas normally the diaphragm contracts concentrically, by which I mean that as it's activated to contract, it's shortening in the zone of apposition, the muscle's getting shorter here, and the dome of the diaphragm is descending. That would be a normal concentric load being applied to the muscle. During an eccentric load, the diaphragm is actually lengthening as it's contracting, and the dome of the diaphragm is rising. You will be familiar with eccentric contractions, say from weightlifting, where when you lift the weight, so let's say you're doing a bicep curl, as you lift the weight, you're contracting your biceps concentrically, but as you lower the weight, you're contracting your biceps eccentrically. And in fact, it's the eccentric loading of the muscle that it induces much greater acute injury and is actually effective to induce a training stimulus because of the acute injury. But if that injury is applied repeatedly over and over again over a period of hours, then rather than having a training effect, it produces a severe deleterious injury. And one paper has demonstrated in an animal model that after a period of eccentric contractions, you have a marked decrease in diaphragm function as measured by the twitch gastric pressure. And this decrease in function persists out for many hours after the brief period of eccentric loading. So eccentric contractions of the diaphragm can be very injurious. When might such contractions develop in the clinical setting? Well, we think that certain forms of dysynchrony may be associated with eccentric loading. So for example, with this case of reverse triggering here seen on the left, you can see that initially the patient is passive, the ventilator is triggered and generates pressure and flow, and then only later the patient's inspiratory effort is activated with this reverse triggering, which as you know is kind of a mysterious phenomenon. But the patient's respiratory muscles contract much later in the breath, and so they actually reach peak effort when the ventilator is in the expiratory phase. So here you've got expiratory flow, lung volume is decreasing, and consequently the dome of the diaphragm is rising. And you can see here that when the diaphragm contracts, it doesn't actually induce inspiratory flow, it just breaks expiratory flow. And this expiratory breaking is a form of eccentric loading that may induce injury. So there's some reason to believe that reverse triggering could cause acute diaphragm weakness. Also during premature cycling, so for example, if you're in pressure targeted ventilation and the ventilator cycles off prematurely, then the patient's effort may be ongoing, and you again see this expiratory flow breaking phenomenon where the muscle is being lengthened even as it contracts. and that may cause eccentric loading. So eccentric myotrauma may actually be fairly common in the clinical setting, and we need more data to confirm that it substantially impacts respiratory muscle function. All right, so those are some of the that's the sort of theoretical mechanistic background. Now I want to present some of the work we've done in the ICU to document this phenomenon and to understand it. And one of the techniques that's turned out to be quite powerful in this regard is diaphragm ultrasound. Now, many of you are probably familiar with the use of diaphragm ultrasound. I don't need to rehearse it in detail, but the basic idea here is that the diaphragm can be visualized in the zone of apposition in cross-section as represented by these dashed blue lines here. And when the muscle contracts, it thickens, and this thickening gives us a way of non-invasively estimating the patient's respiratory effort. The M-mode image here shown on the right represents the thickening of the muscle over time. So you've got an expiratory thickness or resting thickness, and then the increase in thickness during inspiration. The percentage increase in thickness we refer to as the thickening fraction. So here's some of the data that we've collected using the ultrasound technique. So we set out to conduct a prospective cohort study of patients in the ICU, and the first paper we published from this data set was in the first 100 patients or so, where we described 3 different groups of patients. First of all, about 45% of patients had no significant change over time. They did not have an increase or decrease in diaphragm thickness greater than 10% over time, and those patients are represented here. About another 45% had this rapid early decrease in thickness over time, losing about an average of 20% of diaphragm thickness over just 3 to 4 days. So this is a profound, rapid onset diaphragm atrophy, just like had been described experimentally. And this confirmed that many patients are vulnerable to disuse atrophy during mechanical ventilation. And interestingly, another small subset of patients, about 10% or so, had this rapid early increase in diaphragm thickness that persisted over time. And interestingly, those patients tended to have weaker diaphragm and much more prolonged ventilation, which led us to think that possibly this represents a form of injury from acute edema or inflammation within the muscle, rather than a form of hypertrophy. Of course, muscle hypertrophy wouldn't develop that quickly, so it really doesn't make any sense to regard that increase in thickness as evidence of growth in muscle bulk over time. We showed that the direction and rate of change in the diaphragm thickness was proportional to the level of diaphragm contractile activity as measured by the thickening fraction. So in this somewhat complicated looking 3D plot, everybody starts out at 0% change in thickness from a baseline. And then over time, the thickness decreases or increases or stays approximately the same. And the rate and direction of change really varied according to the thickening fraction, which is a measure of how actively the diaphragm is contracting. And interestingly, this intermediate zone here of 20 to 40% thickening fraction is typically what we see in healthy subjects breathing at rest, suggesting that this level of effort might be the right level of effort to preserve thickness. On the other hand, this rapid increase in thickness was associated with very high levels of contractile activity, suggesting that perhaps the increase in thickness over time was the consequence of a load-induced injury or excess loading of the muscle, while clearly the rapid decrease in thickness over time was the consequence of inadequate use of the muscle. So this provided compelling evidence that respiratory effort modulates the structure of the diaphragm over time. Now, we went on to publish subsequent papers looking at the relationship between these measurements and patients' clinical outcomes. And I have to say that of all the point-of-care ultrasound data out there, I'm pretty confident that the relationship between the diaphragm ultrasound and patient outcomes is consistent and very impressive. So, first of all, we found that the baseline muscle mass or baseline thickness of the muscle was strongly associated with patient outcomes. So, if a patient was at the time of intubation had higher muscle mass, that they tended to be liberated from the ventilator more rapidly, as shown here in the yellow line, in comparison to patients with lower muscle mass at baseline. Secondly, patients with lower muscle mass at baseline also had much higher long-term mortality. Here you can see survival declining much more significantly to day 90 in patients with low muscle mass at baseline. So this suggests that the muscle mass of the diaphragm at baseline represents either a certain kind of vulnerability or predisposition, perhaps as a marker of frailty to poor outcome, or alternatively, it's possible that patients who are who have less diaphragm muscle mass at the time they're intubated actually will have a harder time being weaned off mechanical ventilation, and it's playing more of a causal role. But what's clear is that the diaphragm muscle mass is strongly associated with patient outcome. And this is not only true at baseline, but also the change in muscle mass over time. So we showed this interesting curve of the relationship between change in thickness from baseline and the rate at which patients were liberated from mechanical ventilation. So you can see that both decreases in thickness over time and increases in thickness over time were both associated with a reduced probability of being liberated from the ventilator on any given day. And this provides pretty strong evidence to suggest that these changes in the diaphragm that we're seeing in ultrasound are deleterious, and potentially if we could prevent those changes from occurring, that maybe we'd be able to improve the patient's outcome. Similarly, we saw that patients with greater changes in the diaphragm from baseline, either decreases or increases, had more prolonged ICU length of stay. And I think this is important because of all of the short-term ICU endpoints that we measure, this one is very consistently associated with long-term disability across multiple studies. So this suggests that changes in the diaphragm occurring within just 3 to 4 days of instituting mechanical ventilation are associated with short-term surrogate endpoints that in turn predict long-term disability. So these changes in the diaphragm it's possible that they may have a long-term functional impact on patients' outcomes. So now if you hypothesize that the changes in diaphragm thickness, whether greater increases or greater decreases, are the result of deranged respiratory effort, either excessive respiratory effort or insufficient respiratory effort, then you would also expect excessive or insufficient effort to be associated with poor outcome. And we went to the data, interestingly, that's exactly what we found. So this plot here on the y-axis, you have duration of ventilation, and on the x-axis, you have diaphragm thickening fraction on average over the first 3 days of ventilation. And you can see this interesting J-shaped curve here where patients with very low levels of effort during the first 3 days of ventilation, or patients with relatively higher levels of effort, had more prolonged duration of ventilation. And we saw the same thing for duration of ICU length of stay and for risk of death. And this U-shaped relationship persisted after multivariable adjustment. So again, this is not proof of causation, of course, but it strongly suggests that perhaps if we adjusted our approach to ventilation to target an intermediate level of inspiratory effort, we might be able to avoid diaphragm injury and improve outcomes for the patient by accelerating them from the ventilator more quickly. And this is a hypothesis that we put to preliminary test in this Lancet paper, where we looked at this theoretical causal pathway, what we refer to as the Myotron Pathway. So the idea is that the institution of ventilation, but applied inappropriately, results in either excessive or insufficient inspiratory effort, which in turn results in diaphragm injury and atrophy, which in turn lead to prolonged ventilator dependence. And in order to try and test whether this pathway actually exists, we used a technique called mediation analysis, where we looked at the association between how the ventilator is being applied, the pressure and the mode, and the risk of developing diaphragm atrophy or injury. We showed there was a strong association, and we also showed that this association was accounted for by the derangement in inspiratory effort measured on ultrasound. So here the abnormal inspiratory effort seems to mediate the relationship between the way we apply ventilation and the structural change in the diaphragm. And similarly, the changes in the diaphragm seem to mediate a relationship between abnormal inspiratory effort and prolonged ventilator dependence. So this provides corroborating, but again, circumstantial evidence for the existence of this causal pathway. And if this is really the case, then the idea is that if we intervene up front, then maybe we can prevent these downstream poor outcomes and improve outcomes for patients. This is really what gives rise to the concept of diaphragm protective ventilation. So if we can optimize inspiratory effort to prevent myotrauma from developing, if we can avoid the development of reverse triggering and other injurious forms of dysynchrony, then maybe we can improve clinical outcomes. But a fundamental challenge here, as I said earlier, is that there's potential conflict between our efforts to protect the diaphragm and our efforts to protect the lung, because the lung is protected by minimizing stress and strain, whereas the diaphragm is protected, in theory, by activating the diaphragm, which to some extent can increase lung stress and strain. So finding the balance between these two is crucially important. And, there's an increasing body of evidence showing that the respiratory muscles can injure the lung. This is a phenomenon, as you know, that's been referred to as patient self-inflicted lung injury. And there's two basic mechanisms at play. First, the vigorous inspiratory efforts can increase global lung stress. So the true stress being applied to the lung is the transpulmonary pressure, which is the difference between airway pressure and pleural pressure. And so once the respiratory muscles are active, that decreases pleural pressure and therefore will increase transpulmonary pressure. And a nice example here is in these tracings where you have a patient who's on ventilation with pressure swings from 15 to 25 centimeters of water. So pressure swings that just look on the face of it on the ventilator waveforms would not look particularly excessive. But when you have a balloon in place, you can see that the patient's making efforts with swings from 15 down to minus 15 centimeters of water. So those are 30 centimeter of water swings. And so those respiratory muscle efforts in combination with the pressure from the ventilator result in transpulmonary pressure swings of 40 centimeters of water, which is highly injurious. So this is the risk of having the patient breathing spontaneously, that if their efforts are excessive, they can result in excess stress and strain applied to the whole lung. Then there's this other challenge of inhomogeneous lung stress, and this is all the brilliant and beautiful work done by Takeshi Yoshida and Marcelo Amato, Brian Kavanagh, where they describe this phenomenon of pendulift, where in the presence of atelectasis and consolidation, when the respiratory muscles contract, they generate much more pressure at the back of the lung compared to the front, which would generate flow and redistribution of gas from the front of the lung to the back, and this regional excess stress and strain. And the consequence of this, of course, is regional lung injury, which then can propagate throughout the lung. And this phenomenon has been well described. These are EIT tracings here showing that during spontaneous breathing, you can see that volume increases in the dependent lung during inspiration, even as volume decreases in the non-dependent lung. So you actually have gas shifting from the front to the back with a marked increase in the degree of inflation of the dependent lung. And then when you paralyze the subject, you can see that now both dependent or non-dependent and dependent lung volumes increase with inspiration synchronously, and the degree of inflation of the dorsal lung region is markedly reduced. So this highlights the way in which vigorous respiratory efforts can lead to regional lung stress that we can't even detect just by monitoring plateau and driving pressure and tidal volume, etc. So this is an important concern about the idea of reintroducing diaphragm activity, particularly in patients with more severe acute hypoxemic respiratory failure. So how do we tackle the problem? How do we approach this? Well, basically there's a few key issues. First of all, when we're trying to achieve lung and diaphragm protective ventilation, what are we targeting exactly? What targets are we working toward? Secondly, what should we monitor in order to achieve these targets? And thirdly, as I pointed out, a crucial issue is being able to manipulate and modulate respiratory drive and effort. So what are some methods by which we might be able to do that? So I'll just briefly summarize this. So about a year ago now in Milan, I had the privilege with Laurent Bouchard of convening a meeting to develop a position statement on this idea of lung and diaphragm protective ventilation. And so we spent 2 days discussing these issues in considerable depth, and happy to say that the paper describing the discussions and the results of that effort was recently published in the Blue Journal. And essentially, some of the key points emerging from our discussion was that, first of all, now that we're more and more focused on these multiple competing mechanisms of injury, it's clear that you just cannot take a cookbook or recipe-based approach to mechanical ventilation. It's not just 6 mils per kilo and a low PPAP-IO2 table for everybody. We really need to have a more thoughtful approach that takes into account all these various competing mechanisms at the bedside acting at any given time. Secondly, we all agreed that although we care a great deal about the diaphragm, protecting the lung remains the priority over protecting the diaphragm because of the compelling evidence of mortality benefit from lung protection. And I think probably the most important recommendation emerging from this expert discussion was that really, in order to move mechanical ventilation forward, we need to begin monitoring respiratory effort routinely in every ventilated patient. It just does not make sense to have a patient on a ventilator and pay all the attention to what the ventilator is doing and pay no attention to what the patient's doing. We will not be able to understand and appreciate these mechanisms acting at the bedside if we're not monitoring respiratory effort. Some of the key goals proposed in the position statement in terms of doing lung protective ventilation are to limit cyclic lung stress, to limit regional cyclic lung stress by avoiding excess respiratory effort, to maintain a low normal level of respiratory effort, to avoid both excess loading and insufficient loading to the diaphragm, to avoid forms of dysynchrony that would be injurious to the lungs, such as breath stacking dysynchrony, and to avoid forms of dysynchrony that would be injurious to the diaphragm, such as reverse triggering and premature cycling and ineffective triggering, all of which may be associated with eccentric myotrauma. So these are proposed goals of the strategy: paying more attention to effort, paying more attention to synchrony. So how do we monitor the patient? What do we actually do at the bedside in order to achieve these goals? Well, I think the esophageal balloon remains a very important technique in this regard. And although the balloon has been cited as a technique for guiding the setting of PEEP and ARDS without substantial success, I think probably the use of the balloon that I'm more optimistic and more strongly enthusiastic about is using the balloon to monitor respiratory effort and dynamic lung stress during mechanical ventilation. So when you have a balloon in place, you can see that the flow and the pressure being applied by the ventilator here are also resulting from inspiratory efforts from the patient, and you can quantify these swings in transpulmonary pressure in real time on the ventilator. There's several ventilators now that allow you to monitor transpulmonary pressure with the balloon in real time. And so these measurements provide very useful information. So the esophageal pressure swings give you a measure of respiratory effort, which tells you about the risk of myotrauma, whether over assistance or under assistance myotrauma, and also about the risk of excess regional lung stress, because if respiratory effort levels are low, then the risk of excess regional stress is very low. The transpulmonary pressure swings tell you about the cyclic lung stress applied to the whole lung, and hence the risk of volutrauma. And so right here you have all the information you need in order to do lung and diaphragm protective ventilation. Now the problem, of course, is that not every ventilator allows you to make these measurements, and not every ICU is familiar or comfortable with esophageal manometry. So we really need techniques that are simpler and easier. And one that has been described recently, and congratulations to José on publishing this very elegant summary of the technique in intensive care medicine last week, is a measurement we call the POCC, or the occlusion pressure. And this is slightly different from the traditional airway occlusion pressure, which was an occlusion for just 100 milliseconds. Here we're applying an occlusion for a single entire breath. And so what happens when you do this is that the patient's effort, which is the so-called submarine that's submerged under the water, becomes evident, because as the patient makes an effort against the occluded airway, this negative pressure deflection represents the pressure that their respiratory muscles are generating. And so now you have a simple way of seeing, are the muscles contracting? Is the patient generating any pressure with their muscles? And secondly, just how much pressure are they generating? And in a study that published last year by Michele Bertoni and colleagues, they showed that these correction factors here, these could allow you to quite easily predict both PMUS and transpulmonary driving pressure quite easily from the measurement of POCC during mechanical ventilation. So now in our ICU, our RTs are actually measuring POCC as along with P01 every 4 hours as a routine measure of respiratory effort. And I have to say, it's surprising just how often we have patients who are either unexpectedly completely apneic, even under pressure support because they're auto-triggering, or patients with massive respiratory efforts that you wouldn't have expected. For example, this morning I rounded on a patient generating a tidal volume of 400 cc's on CPAP of 5, breathing quite comfortably, but the POCC was 30 centimeters of water, which suggests quite a vigorous respiratory effort underneath. And it's really something that we don't pick up if we're not looking for it. So I think this technique could be very useful to assess both the risk of myotrauma and the risk of volutrauma for a lung and diaphragm protective ventilation strategy. So the challenge then is, having identified patients with respiratory drive and effort that's either too low or too high, what do we do about it? And so, of course, we talk about paying attention to ensuring that ventilator support is not insufficient or excessive, and that's the first place to start. But it's clear that there are other factors that are important contributors to abnormal respiratory drive and effort. And I think sedation is a big piece of this. So it's not just the way that we ventilate patients, it's also about the way that we sedate patients. And when you have a patient sedated, then it doesn't take much mechanical ventilation to render them completely apneic. And so we need to be titrating our sedation not only to the level of wakefulness, but also potentially to the patient's respiratory effort. And of course, extracorporeal life support and CO2 clearance can also have an important effect on respiratory drive and effort. And all of these things together modulate the risk of myotrauma and the risk of patient self-inflicted lung injury. So for example, thinking about the influence of sedation on respiratory effort, it's not widely appreciated that, in fact, there's no relationship between the depth of sedation measured by SAS or RAS and the patient's respiratory drive and effort. We can have patients with a very low SAS who actually exhibit quite high respiratory efforts, and patients with a SAS of 4 to 5 whose respiratory effort is relatively low. And different sedatives have different effects on respiratory pattern and effort of breathing. And so these issues need to be taken into consideration when designing sedation strategy. And I think the ideal sedation strategy is one that induces a rapid shallow breathing pattern, because that means that the patient's making efforts to breathe. They're going to be triggering the ventilator, and the ventilator doesn't easily exceed their own intrinsic minute ventilation. But at the same time, their efforts are small enough that they're not going to be causing injury to the lung. Another important issue that we're working on is the way in which PEEP can modulate respiratory effort. In many patients, PEEP can significantly increase or decrease respiratory effort. And this is something that we don't normally pay much attention to when we're titrating PEEP. We pay attention to gas exchange, to lung mechanics, and transpulmonary pressure and other markers of lung function. But the way in which modulating the PEEP can significantly attenuate a patient's respiratory effort is not well appreciated. But this may be critically important to maintaining lung and diaphragm protective conditions, because if you recruit the lung, reduce a patient's effort, and increase the size of the baby lung, you're going to decrease dynamic stress and allow spontaneous breathing while maintaining relatively protective transpulmonary driving pressures. And then, of course, there's the question of whether the use of extracorporeal life support may have an important role here in modulating respiratory drive and effort. And it's been long been established that you can modulate a patient's respiratory drive and ventilatory demands by clearing CO2 with an extracorporeal circuit. So perhaps there's a role for ECOR as a technique for achieving lung and diaphragm protective ventilation. Just to briefly mention some of the ongoing studies, this is really important work that José's leading here in our ICU, the landmark trial, where we're attempting to titrate ventilator support and sedation to achieve lung and diaphragm protective goals. with the simple question is it actually feasible to do this? Can you achieve a state in patients with acute hypoxemic respiratory failure where it appears that the lung is protected and the diaphragm is protected? What role does higher versus lower P play in this? What role does sedation play in this? And what role does extracorporeal CO2 removal play in this? So I think this challenging but very important study will yield lots of insights about how we might do this in future clinical trials. We're working on with a group of engineers here at the University of Toronto to develop potentially an artificial intelligence technique that can provide decision support to help clinicians identify how to set the sedation and the ventilator to achieve optimal conditions. And we're also doing work in patients who are being bridged to lung transplant on extracorporeal life support to see whether extracorporeal life support is associated with less diaphragm atrophy and injury in comparison to mechanical ventilation. So just to sum up here, we've talked about the idea of lung and diaphragm protective ventilation as the integration of three different ventilation targets: avoiding volutrauma, avoiding myotrauma, while maintaining adequate respiratory homeostasis. And if we can optimize all three targets, then we hope that we can improve clinical outcomes. And in order to do this, we need a combination of a lung protective approach and a diaphragm protective approach. And in order to achieve these goals, which may conflict at times, we need to be paying attention both to the way we set the ventilator, the way we apply sedation, and potentially the adjunctive role of extracorporeal CO2 removal in certain patients. So that's all. Thank you very much.